Okay, I think we'll at least begin. I want to thank everyone for attending the Scientific Communication Workshop 2. We have some excellent presenters today, panelists today, I should say. And Dr. Kenneth Snyder is here, and Dr. Gale Burstein is, I'm sure, on her way. And we're going to have this facilitated by Diane Schwartz, who you did, if you came last week, did see her do an introduction to the presentation, and also ended the presentation because she is the lead on this particular workshop series. I do want to tell you that I'm going to be putting in the chat a link to all of our workshops because we have, it looks like 4 more in responsible conduct of research, which is taking place on Mondays. And there's 2 more in this series as well. And then there will be one, it's a kind of a hybrid a biomedical informatics series that Dr. Peter Alkin will be doing the presentation of the first one. And then that can lead you in, if you wish to pursue things further, into his free boot camp, which is really a great opportunity to really explore the field of biomedical informatics. I do also want to tell you that there is a micro-credential associated with this workshop. So if you're interested in that, there are some assignments that go along with them. And you can build your own timeline as far as when you'd like to get that done. We're very flexible with that. But if you're looking for a digital badge to showcase your skills in scientific communication, we can do that. Just email me, and I will also put that in the chat. I'm Catherine Sedota, and I'll put my email in the chat. If you attend all 4 of this series, you will receive a certificate of completion a couple weeks after the series ends. And I'm going to be placing a survey in the chat as well a couple of times. So we ask that you try to your personal best to complete that. If you don't complete it during this time, then I'm also going to be sending it to you a couple of times. And that's used in order to report to our funding sources and also to improve the series, which we've actually done quite well in this cycle. And at this time, I'm going to now turn this over to Diane Schwartz, who is our facilitator for this workshop, and she can start the process. And right now we have one of our presenters here, and I'm sure the other one will be coming on soon. Thank you very much. And Diane, over to you.
Thank you, Catherine, and welcome everybody. It's nice to see some familiar names up on the screen, and we have a very interesting program. We've been making a lot of changes this year, and a lot of our changes every year are the result of feedback we get from each of you who attend the sessions. I know some people come to just 1 or 2, but when we ask for your feedback, we really appreciate getting a response because it helps us keep the program vibrant, up to date, informative, and user-friendly. That's our key word. So I'm going to start out by introducing Dr. Kenneth Snyder, who is an associate professor, correct?
Yes.
Of neurosurgery at the University of Buffalo. He's also the head of quality for the Kaleida Health System. And he's a very good presenter because I know he just presented to a class that I teach this spring semester last week. And we really had a good time, and he's very engaging. So to kick off that engagement, I'm going to ask you a question, Dr. Snyder. We look at the basis of information sharing and how patients particularly, or consumers, it could be a patient's child, a caregiver, all sorts of people. But how do you know if lay people, especially your patients, are understanding the scientific information that is provided to them to help make good health decisions? I know it's difficult. I've spent many years working in that area, and I know it's a challenge. So we're interested to hear from you as an experienced communicator and a professor too. So you do a lot of teaching and I know a lot of presentations.
So I'll take a shot at answering it and give you my best answer. And I did put together some slides. I've got about 10, 15 minutes worth of presentation that may help also gauge some of the conversation or engage others in questions along the way. That some of the presentation will get to, I think, what we're getting at, but I think a simple answer is asking the patient or the patient and their family to feedback to you what they heard. It helps in so many ways. Just where they begin that response will help you understand where they're coming from in the response. And again, what do I mean by that? Sometimes I'll go off on a tangent explaining something completely, and yet what they want to focus on isn't even necessarily the context or goal of where I'm heading in the direction. So what I've learned to do is a couple things. The first thing is sometimes say, if I had a magic wand and I could make one thing better in your health today, what is it? It's a wonderful way of gauging whether or not what's on the patient's radar for the goal for that visit is even the same as what yours is. Because, hi, Dr. Burstein. Because sometimes they're coming at the appointment from a completely different angle, right? They're not even necessarily sure why they're there to see you. And so grounding the expectation of the visit sometimes really helps before you then enter into the nuance of the data or the risk benefit conversation that you want to get into. So I'm not sure that answered the question, but that's how I like to frame things really from an expectation management standpoint, even before you dig in. And then the only other point I'd like to add is sometimes one visit isn't enough. And if we're fortunate that there isn't an urgency or emergency, giving information, giving a brochure, giving time, ensuring they have a second opinion and hear it from someone else, and then bringing them back. And of course, that's overlaid with the criticality of the importance of language services. Sometimes just because somebody's nodding at you doesn't mean they understand your words. And so really being clear that an interpreter service is used when needed. Just a couple pearls at a high level to answer the question, and maybe feed some information to set up for a short PowerPoint at some point during our talk.
Well, you sort of implied an answer to the second part of that question, and that is, how do you know if people use the scientific information you provided in that second visit? If you're so fortunate as to bring them back for a second visit, do you provide? Does it give you an opportunity to probe with the individuals, see what they're doing, if any?
Yeah, there's multiple different types of patients that we see. Some patients will come in with an already well done literature search and 100 questions that they want to get answered. Some people come in and say, well, you're my doctor. Aren't I paying you to tell me what to do? And then there's a whole lot of people in between. And so that expectation management of grounding each conversation of treating every patient like they're your family. And often you get that question, if this was your mother, brother, family, sister, what would you say? And often preempting the conversation with, if I'm talking to you as if you were my mother, brother. And what's also very interesting is I think ways of allowing them to frame that there always isn't a right answer, and sometimes trying to over calculate what we think is the right thing isn't necessarily the right thing. And I'll often preface it by, I could give the same risk benefit conversation to my mother and my father. My mother will want every procedure known to mankind done into her hundreds. My father, I will not be able to get into the hospital. It will take every power of mine to persuade him to come in to get his diabetes controlled and checked. They're in their 80s. My job is to empower them with the decision to make the right decisions for each of them. And that's all we can do. And so it's just coming at that conversation as best we can to give them the information that they're seeking and make sure they're asking the right questions, and understanding the implications of the different types of responses, and also knowing that, again, it's not a right or wrong answer. You can choose no today, but if something changes tomorrow, you must re-engage, and let's ask those questions again tomorrow and revisit it.
And I would imagine that's particularly true as people age.
100%. And I'm sad to say I can't tell you how many people above their 50s or 60s don't have any advanced care plans in their records or in their charts. And the hardest thing about those conversations for physicians and for family members is that then when the crisis hits, everyone wants everything done because they don't know what their parents or loved one want. They haven't had clear conversations. And it's part of the reason why our cost of care is so exponential as we're aging in life. And so again, I think one of the important, it's difficult to have these conversations. It's difficult because we all don't have crystal balls, but the more we engage our patients in thoughtful conversations of what ifs, the better we serve them.
Let me turn to
Diane,
the-
I'm sorry, Diane. Dr. Snyder said he had a few slides that he wanted to show. Do you know when would be a good time for him to show those?
Want to do that now, or shall we?
Totally up to him, whatever he would prefer.
Sure. And again, I'll try and make it 10 minutes, but I wanted to give some color or context and also illustrate some of the complexity and nuance. And then it may help other people trigger some ideas of questions if that's okay with you.
Oh, excellent.
Excellent. And then we'll move on to Dr. Burstein. Is that good with you?
Dr. Burstein, I'm flexible. Is that okay with your
Yeah,
schedule?
whatever. I'm flexible too.
Great.
Thank you both.
Okay. So I know we covered some of this, but I want to illustrate for students or the broad range of people that might watch this. You know, we're a teaching institute, and I had, again, blessing and pleasure, Diana, teaching in your class, and also had Dr. Burstein and teaching to all first-year med students. And one thing I like to tell the students is that, you know, what makes you different than the general population? Well, when you signed up for med school or for your learning, you signed up to learn three things. You signed up to learn what's the evidence of effectiveness, I don't care if it's a medicine or a surgical procedure, of whatever intervention that you're going to be talking to your patient about. You have to understand the risks involved and how those risks are managed, and you have to understand the mechanism of action. It's the mechanism of action and that knowledge base that makes you different than the general population. That's what you're communicating on each and every office visit that you're interacting with your patients on. Every single disease process, just about, has a published guideline of expected management within the specialty that you practice in. You could just do a Google search for many of these and get an outline of what best practice looks like. First, most important principle, a guideline doesn't mean it's followed every single time. A guideline is a guideline. What's important about guidelines is you know maybe what happens a good majority of time, but it also means that when you're not following a specific guideline for a reason, that's what you should be highlighting with the patient and what you should be documenting. So just because it's a guideline doesn't mean it fits your patient, but it's a good basis of beginning and transmitting information. Every guideline is broken down by its strength or class of its formal recommendation, from very strong recommendation through no real benefit to harm, and understanding that we've published and learned on each of those spectrums. And then learning about the evidence or quality of data, multiple randomized controlled trials, meta-analysis only, case series. And so there's a component of strength of data and quality of evidence that isn't as clear cut. It's expert opinion often that helps you gauge which these fit into in time. But it's important to know that these are already laid out for you as you're thinking through treatment strategies. And so, for example, for head and neck imaging for stroke, acute ischemic stroke presentations, you'll see that there's high level 1 evidence with its highest level of evidence reported for the types of imaging that patients should get when they come in. But once you start talking about who's candidates, the time frame, and other issues, you notice that, well, there's no randomized, non-randomized controlled level B for the effectiveness of, let's say, MRI to exclude ICH before TPA. And so there are nuances to this with great references, and it's a good place for people trying to learn about a disease process to begin. And any practitioner that's going to be speaking to patients about it, they should have that as a foundational basis. I'm going to give one example of the complexity of nuance. Carotid disease is one of the highest studied of all of our surgical disease processes. You can have an open surgical procedure called carotid endarterectomy, where we open up the plaque and sew the vessel back together. You can do carotid stenting. You could do hybrid stenting and open surgeries, or you can do medical management. And the effectiveness of medical management has changed over the decades in terms of how good we are at treating this disease. And that's important as you're trying to read the literature or understand the literature. The other thing is we're inherently terrible at probability. And when we tell our patients 1 in 3,000 in terms of a risk, I don't know if people compute it. I joke that there's this movie where a comedian was told, not in a million years would I date you. And the comedian goes, that means there's a chance. And so there's this, we have a terrible way of understanding what 1 out of a large number means. Because if the complication occurs, it occurred to you, and you're that one. And so we really have to spend time on probability. 3 simple examples that I'll wrap up quickly. Massive trials in carotid disease. The asymptomatic carotid atherosclerotic study, meaning no one had a stroke or minor stroke, completely asymptomatic disease. People that had surgical procedures for symptomatic carotids, and then a trial called CREST where we looked at asymptomatic and symptomatic endart and stent and asked what's better. This is an example of the type of data you get from a high-level study, okay? This was really to determine that whether or not what endarterectomy did to help medical management of carotid stenosis. It was a prospective randomized multi-center trial, 39 clinical sites across US and Canada, over 1,600 patients. Anybody greater than 60% of stenosis was included. The intervention was aspirin on the medical arm, and then it was carotid endarterectomy on the other. Again, why is that even nuance complicated? A single dose of aspirin, nowadays we have an aspirin response test. We've learned that you can give somebody an aspirin and it has no effect on their blood. We can give other people, it takes massive doses of aspirin to get therapeutic. We didn't know that then. And so the outcome was a reduction in stroke on either arm. And the results are in a median follow-up of almost 3 years of 4, 6, 5, 7 patient years of observation over 5 years, 5-year risk of ipsilateral stroke, 5.1% in the surgical arm, 11% in the medically treated arm. And so the conclusion is for asymptomatic carotid disease, 60% reduction or 60% or greater, that people are candidates for an elective surgery, have a 5-year risk of ipsilateral stroke, much less than the medical arm, as long as you can perform the surgery with a less than 3% morbidity and mortality. So one of the problems is people take this data and then regurgitate it back to a patient. This is very complex and nuanced data outcome. First of all, the data is distributed over a 5-year time frame. If you tell someone they have a 5% risk of event over 5 years, that's already confusing enough. You've got to reduce everything down to a yearly risk by year to that individual. This is a simple nuance. And so when you tell somebody, one of the main surprises or one of the things that's really important for people to know is this means that medically treated people have about a 10, 11% over a 5-year risk. That's only 2% per year. How many people would have thought that 60% or more stenosis means your risk factor for stroke is only 2% per year? And you'd go to surgery, it's 1%. And that's per year. And so now you've got to get through the nuance of, well, what's my cumulative risk per life? Why would I undergo a surgery that's got a 3% risk of a problem to reduce a 2% risk to 1% risk? Well, because you're 55 years old and I expect you to live till you're 85. And there's a cumulative added risk for all that. And then there's an additional nuance. We aggregated everyone with the stenosis over 60%. I didn't tell you that there's higher risk for people 80 or 90%, or if there's other factors that element into it. And so being comfortable talking in nuance is really critical. You can oversimplify to a point where you're not explaining anything useful to someone. This is the complexity of the symptomatic trial of massive study, again, multi-center, 106 centers, 2,000 and more patients. What's interesting, again, in this one, in breaking down the degrees of stenosis, is they add a need to treat number. If you did surgery on 15 people, you saved a major stroke event. Again, an interesting number. Some people will relate to the percentage changes. Some people will relate to the number needed to treat before you save a life or save a stroke. And again, you've got this nuance of data over 5 years, which is meaningless to somebody. You've got to reduce everything down to a single year. Add the complexity of we do over 60 clinical trials in carotid stenting almost every year here in Buffalo, in addition to those. How do I start to incorporate all the nuances of each of these studies and devices to help give someone a formal recommendation? By the way, every trial has a massive number of exclusion criteria, and I guarantee you the patient in front of you has every one of these exclusions because they tried to really streamline the data to get a certain, optimal outcome. They didn't take a perfect snapshot of the patient population that you would be treating. So you've got to automatically make an inference from the idealized study population to the patient that they're in front of you, and that is an additional art form. You've got to take in the nuances of the uniqueness of that person's anatomy and how that adds added risk to that overall aggregate number that we pulled forward. You've got to realize that the surgical risk isn't always just 3% because the technique may change depending on what that person's had done. If they've had radiation surgery to their neck, if they have an occlusion on the other side, depending on the location of their lesion. All of these nuanced features are critical. I'm going to end in 1 minute and then open back up to questions. But again, I'm hoping this adds color to to why someone who's got 20 years of experience in explaining this problem to people gets more and more and more comfortable in the nuance and better at it, and why it might be difficult for someone 1 year out into practice to effectively communicate the nuance. So then we did a huge randomized multi-center study looking at the aggregate, 108 US centers, 9 Canadian centers. And what we found out was that, the risk depends on what questions you ask. For carotid stenting, it's got a 4% risk of minor stroke in a short period of time, but it's got a 2% risk of MI compared to carotid endarterectomy. So if you ask total risk, well, there might be a little bit more risk with stenting, but which one would you, which risk of there is there a difference? The other element, cranial nerve injuries with open surgery, none with stenting. So when I have a vocalist or a singer that knows they might be impacted, they never want the endarterectomy, even though there's a small risk of cranial nerve injury. They all want the stenting. You have to understand that level of nuance. And this was the outcome of the CREST study. It meant that there wasn't a single right answer for everyone. It meant that we were surprised that endarterectomy was favorable for the elderly population, exactly who we thought the stenting was best for. Well, what we learned was that the nuance of how difficult the tortuosity of the arch and the carotid gets as we age with hypertension made it very hard to treat from inside the blood vessels. And stenting was actually easier when our vessels were straight, and that the open surgery was better for the elderly. And so, this is how I start and simplify that guideline of all of the data which I showed you. I begin by just breaking things down into yearly numbers. And I tell people that if you don't have never had a stroke before and you're completely asymptomatic, best medical treatment, you have a risk if you're above 60% of about 2% per year. If we did surgery, it would be 1% per year reduction. If you're symptomatic with a 50 to 69% stenosis or greater than 70% stenosis, with best medical management, you have a risk of stroke goes up dramatically between 4% and now 10 to 13% per year. Now you're starting to get into a really significant number, and this adds up every year of your life, aggregate. When we do surgery, we reduce that risk significantly by more than 50%, as long as our surgical complication risk is low. So these are my summary points, if I can get to them. Whoops, that may help. Simplify the data yourself before trying to explain it to others. Don't oversimplify it. Be comfortable explaining nuance. Reduce probabilities to a yearly risk number and explain how the risks, if they happen, might be managed. Take time to explain it over multiple sessions when possible. Share what's known and unknown. You gain a lot of credibility when you tell your patients, we just don't know the answer to this yet, and we're trying to study it. take time to explain it again over multiple sessions. I said share data with them to take home, ensure no language barriers. And for me, I always, always, always recommend multiple opinions. So I hope that was helpful. I'll stop sharing and then hopefully we can continue the conversation.
Very good. Excellent. Thank you so much.
You know, Diane, though, I think we do have a question in chat. Alice, do you want to
Oh.
ask? I'm not sure if he already answered your questions, but you do have a couple of questions. So would you like to share that, or would you like me to read what you have?
Sure, I can share. I think you
Okay.
kind of alluded to this, but when you're speaking to patients, obviously in different trials, like the first one that you presented, I couldn't see age or what your population looked like. So
Yeah.
are you looking at your homogeneity between your patient and the sample and the age between the patient and the sample? And like you said, a lot of people are excluded in randomized controlled trials. So
Yes.
your outliers, which you see every day, are not included. So how do you manage that when you're
Yeah. Yeah. And age is the least of my problems. Again, I don't know if you noticed, some trials have 19 contraindications, comorbidities that everybody has are excluded. And that's an even higher risk profile. And so let's say, to take your point, Alice, pediatric patient population, right? Most studies are going to be somebody 18 and less than 90. Let's say 18 to 80, okay? You may learn something in that population. Now you've got to figure out, can I translate it to my 20 or 15-year-old that I'm taking care of, or my, these days, 94-year-old that wants to consider treatment as a risk factor. But more to your point is, boy, they have severe aortic stenosis. They have a cancer history. How do I take that into account from a prognostic and risk measure as we talk about this new problem that we're facing, and then prioritize that within the risks of what might come up from that disease process? That's where, again, the nuance and clarity come about. So what do? Just as you alluded to, I tell them who was in the study, what we learned from that study, and how I'm thinking about it, but that they wouldn't have been enrolled in that trial. But either way, I also share with them, even if you were in the trial, it's still a population-based probability number of what might occur. Here's how I'm thinking about it. Here's how I best thinking about it if I were in your shoes, and then we have a conversation.
Okay, thank you for that.
Mm-hmm.
The other question I had was, and you said reduce it down to yearly risk, which makes a lot of sense, but is actual risk or relative risk better for communicating to patients? What do you prefer? I mean,
yeah, everyone's different.
Yeah.
I'll tell you what, people struggle with absolute risk and relative risk. They struggle with any probability.
Some doctors do too, I have to say.
I do find need to treat numbers very helpful. You know, when I'm comparing studies or comparing opportunities and I say, you know, we have to do 26 of these surgeries to prevent an outcome, whereas in this one, I only have to do 4, right?
Yeah.
When I compare endarterectomy or carotid procedures versus a thrombectomy, using those levels of numbers and that recognition that, oh my God, that's that much more powerful of a response,
Yeah.
I find is helpful. And once, in my experience, once you're down to slivering risk in that way, I'm not sure people really know how to process it. They often the conversation, even no, it could be a 30-minute conversation. I guarantee you at some point it ends with, if this was your family member or it was you, what would you do? And you just have to be very comfortable answering that question genuinely as best you could with that level of nuance.
Excellent. Thank you.
Mm-hmm.
Any other comments or questions for Dr. Snyder? Okay, there's always the chat. We'll keep an eye on the chat, but I'd like to move on now with Dr. Burstein, and it's a pleasure to introduce to all of you Dr. Gale Burstein, whom I've had the pleasure of working with over many years now. She's a great, she joins my public health informatics course, and the students just love having her participate with them. Very casual, right? Easygoing, and she's
Yes.
really comfortable.
Great class.
Yeah, it is a great class. I'm proud of it. But we have kind of an interesting public health question for you. Dr. Burstein, by the way, is the Commissioner of Health for Erie County, just in case you didn't know that.
Thanks. And a pediatrician.
And a pediatrician. I almost forgot that. So our question for you is, looking at a diverse group of individuals, maybe people of different race and ethnicity, gender differences, literacy and educational levels, health beliefs, sexual orientation, all of those sort of population-based issues. How do you find information given, the emphasis that the department has on educating its constituency to fulfill the needs of a diverse group of people? And we'd like to sort of bring the conversation to focus on the opioid crisis that we've had in Erie County. It's been enormous.
Sure. Well, so some good general principles is that good science communication follows good general communication principles because you're just communicating. So first of all, you have to know your communication goal. So you want to know what you want to achieve, what kind of attitudes or behavior do you want to affect or change. And you have to know your audience and the best way to communicate with them. So is there a best channel or medium or time, or how do you best reach this audience that you're really need to communicate with? And also you have to find a credible messenger. So because people like to hear information from people who are look like them or from similar backgrounds, and they're really more what we call credible messengers. So we have to try to find a credible messenger to deliver that message. And then we also have to develop a compelling message. It just can't be boring and just data. It's good to use personal stories too and experiences, or just like Dr. Snyder did, some charts or bar graphs or pictures. They can really tell a story. Also, you have to is any type of intervention, just like communication is an intervention, you need to measure your impact. So you need some objective data. So to see how how many people heard this, and then do you see any changes that were temporally associated with your communication message? So because remember, communication is a two-way street, and if you don't see any impact from that message, how you deliver that message, you just can't keep doing that. You have to figure out how to better deliver it, or what type of better message or a different credible messenger would really be able to impact your target population. Also, we make sure that since we're all in healthcare, you have to make sure that we use plain language that people can understand. Try to avoid any type of acronyms or make sure if you do use an acronym that you define it so everybody knows what you're talking about, and, don't act like you're the smartest person in the room. And then also we have to be careful, especially when we're talking about, say, the opioid epidemic or any type of behavior or disease, that we avoid stigmatizing language. So, we have to make sure that we, talk to people and meet them where they are. So, like in a clinical settings, when we're talking about substance use disorder, we avoid language like in the clinical setting, dirty and clean. I mean, you're talking about a laboratory test result, so it's positive or negative for, whatever you're testing for. You have to avoid words like, addict or junkie. I mean, it's person with it's first person language. So this is a person with a substance use disorder, with an opioid use disorder, not an opioid addict or a drug addict. So you just have to, remember that type of language, and just, put yourself in that person's shoes. You want to think about, how you would want to be communicated to. And, it's not only the words that we use, it's also the nonverbal cues in our body language that is also important. So if you're using nonverbal cues that show kind of disgust or boredom or I wish I were somewhere else, I mean, that's really not going to build trust with your audience, and that's not really effective way to communicate. So with our drug overdose epidemic, we were able to use money from the pharmaceutical settlement funds to hire actually a professional media company called impact marketing, and we were able to develop a media campaign that we think has been successful because we've been able to evaluate it. So I don't know if you've seen anything or heard anything on the radio about it. It's called Detect to Protect, and it's for drug overdose prevention. It's really harm reduction. And so this is a multi-year, multiple channels. We use radio because we found that our target audience listens to radio. We found out what stations they listen to. We use print and social media. And we use images from community members. So, people from the community who are directly affected. And so that reflects the demographics. So we're getting people that look like the people that we're trying to target. And we've developed messages based on community feedback. So we had a draft message, and they went out and piloted that message and received feedback from people, part of this audience that we really want to reach. And then now we are evaluating those messages. So we have did some again looking at our data and see like number of Narcan number of Narcan doses that were ordered, a number of fentanyl test strips. We've also we looked at different outcomes like process outcomes, like how many times the ads were played on the radio, and then our primary outcomes that we were looking at is how the number of orders of Narcan and test strips, and then also ultimately, are we seeing fewer deaths? So that's what we're looking at. And the target audience that we have been trying to reach has actually changed over time. So, and that changed with the epidemic. So initially, the target audience that was really affected were young people in their late teens, 20s, and early 30s. The target population was that was dying of opioid overdoses were primarily males and primarily white. And now, fast forward, we think we have to really think about this as a drug overdose epidemic, not just an opioid epidemic, because we're seeing just as many, the same percentage of people with a positive tox screen for cocaine as we are with a positive tox screen for fentanyl. So, so this audience is older adults, like boomers and beyond. So people in their like 50s, 60s, 70s. We're seeing more people of color, more Black, brown individuals. So about 14% of our Erie County population is categorized as Black, brown by the U.S. Census, and about a third, I think like 33% of our drug overdose death victims are categorized as Black, brown on their death certificate. So, and then also, we have to target people who are using cocaine or they think they're using cocaine. So again, it's a different audience. So, we've had some challenges with that, but looking at our outcomes, I think we've seen some success. In 2024 was the first year where since before the COVID-19 pandemic that we've started to see a decline in drug overdose deaths, including opioid overdose deaths. We saw a 17% of overall drug overdose death decrease between 2023 and 2024, and we saw a 25% opioid overdose death decrease between that time. So we're hoping, again, all our interventions, it's multifactorial, but I think our media campaign did contribute to this.
Very interesting, isn't it? It's just amazing. Questions for Dr. Burstein, and of course, or Dr. Snyder.
Nothing in the chat at this time. I'll be happy to just kind of interject when I see one.
Okay. All right. So we've created one more question, and it's actually got two parts to it, but it's built around what's really a very hot topic right now, not just misinformation, but disinformation also. And it has become front and center. What was I just hearing about? Some way to help prevent measles? Something new. Oh, gee.
Yeah, I think it's like
something.
tests like cod liver oil or castor oil or something like that. He also
Equivalent to
recommended vitamin A.
Vitamin A.
Vitamin A.
I mean,
That's
vitamin A has been shown to be effective in decreasing adverse outcomes in children in developing countries who are already infected, who are probably have vitamin A deficiency, who already are infected with measles. So this is a treatment for measles, a partial treatment for measles. It does not prevent measles at all. And this is it's been shown to be effective at preventing adverse outcomes in developing countries among children that we believe have some level of vitamin A deficiency. We don't have any data to show how that would be effective in the United States, where probably children do not have vitamin A deficiency.
Thank you. Yeah, thank you for remembering those details. There's
And
a
I'm
question.
glad you mentioned that, because we do have a person with a question about Erie County and measles. And since we just got off that, do you mind if Alice asked that question?
Sure.
Thanks.
Hi, Dr. Bernstein.
Hey.
I just did a quick search of Erie County, and I saw there's 3 or 4 zip codes that have between 60 and 70% of MMR vaccination. I don't know how accurate that is, but that's as of January 1st, 2025. So in the county, are you doing anything specifically to increase information, decrease disinformation, and kind of try to avoid that from happening where you are?
Right. Well, first of all, just let me explain what those data are that the New York State Health Department presents. So those are the proportion of children who are 3 years old, of 3-year-old children who've received at least one MMR dose by the time they're 2. So if they received it like a month after they were 2, they didn't get credit for it. So, but anyway, I mean, needs like some way to look at data and follow trends, and then, compare different zip codes. So that's the data that they use. So, what we've been, we're working with our pediatric partners, and, being aggressive about, giving, the pediatricians are giving strong recommendations. Well, so the problem is most of the pediatricians are giving strong recommendations to get the MMR vaccine on schedule, because there are these different myths out there, and people are worried that they're going to overwhelm their children by giving too many vaccines at once, when actually, especially if they go to daycare, they're exposed to like thousands of pathogens every day. So like just a couple of, even like 10 or 20 exposures to like antigen proteins, or like attenuated virus is like a drop in the bucket for what they always get exposed to. And we actually don't, and so they and also, so sometimes families want to use like a different schedule and not get all the vaccines at once. However, we don't have any data about the vaccine effectiveness in an alternative schedule. So actually we tell the parents that they're actually performing experiments on their children. And the more times they have to come in for shots, I mean, the more painful it is and traumatizing it is. So pediatricians have already been trained to provide strong recommendations to their patients that is an evidence-based approach to improve vaccine uptake. And we've also been reinforcing that with we put out a press release a couple weeks ago, and then just the community just explaining about the safety and effectiveness of the MMR vaccine. And we also put out recommendations that if for adults can get measles and die from measles too. I mean and there was one of the New Mexico measles deaths was among an adult. So we also put out, echoed the American College of Physicians recommendations that if, adults are unsure of their measles immune status, and they can't get a hold of their childhood vaccine records, and, they're not sure if they've ever received a measles vaccine, or if it was, in the 1960s, the killed virus vaccine and only one dose. I mean, that's not going to be that protective. So the American College of Physicians says just vaccinate them, just get another vaccine, because the benefits greatly outweigh the risks. It's a very safe and effective vaccine. And we've also put out that message to our physician community, the pediatricians, and also, adult medicine, and just, reminding them it's just easy just to, give an extra MMR dose. We're holding a vaccine clinic at the Harvest House between 10 to 2 o'clock on this coming Thursday to offer people the opportunity to get a measles vaccine. But it's it's really a combined effort and just having one strong message. We're also putting our messages out on the social media that we use at the health department. We don't use X or Twitter anymore because that's not credible. But it's it's really challenging because CDC and is not putting out those strong pro-vaccine messages anymore. And also, we've learned that in our community in Erie County, there are new medical offices that have opened that actually promote like pro-choice for vaccines. And they actually discourage families to get vaccinated. On their website, they have a blog, and the providers have posted that they've chosen not to vaccinate their children, and they encourage other families to do the same. So it's it's a very difficult time right now, and I think that this measles outbreak is like just breathing down our neck. I mean, last week I was able to participate on a call through the National Association of County and City Health Officials with the local health department leadership in Texas, where they were experiencing the outbreak, and their hands are tied to control the outbreak right now. I mean, because their local government will not allow them to mandate vaccines. They will not allow them to mandate isolation for those cases or quarantine for those who've been exposed. And measles is like the most contagious infectious disease. I mean, if it, the infectious particles like hang out in the air for up to 2 hours after a person has an active case has been in an area. So you can imagine if somebody with who's like shedding measles virus goes to shopping at like Wegmans, like everybody in Wegmans is, while they were there, considered exposed, plus all the people that go in up to 2 hours after they leave. So I mean, it's crazy outbreak. And also, it's like speaking to the public health official in Texas, and then also looking at their data, they have a lot more cases than just the 200 that they report. Well, first of all, they said that people aren't going into care, so they're not being identified. And then also, I think they have different rules in Texas and in New Mexico, because not all cases are being reported. The health department official found out, like, from somebody that she knows, that there was at that time there were two patients with measles admitted to the hospital, but she found out through indirect informal channels, not through direct reporting channels. And then also the measles death rate is 1 to 3 deaths per 1,000 cases. So we've already had 2 deaths. So there are more than 200 cases, but we just have no idea. Yeah. So spring break is let the games begin. People are going to be traveling, and that's how infectious diseases spread. So I think we have to do everything we can to get as many people immunized as possible in our community to prevent measles from infiltrating.
Diane, Alice, I wanted to add some color as well. And again, we're blessed to have Dr. Burstein helping keep our community safe and each of us safe. You can tell that she stays up at night thinking about this stuff. She worries about each of these issues for all of us, right? It's also how you can tell when you're lucky enough to be in your sweet spot doing what you're supposed to be doing. So we're very fortunate to have you leading us.
You
What
know,
I
I
was just,
stay up late at night for my 3 a.m. emails.
I know, so I don't know how you keep up. But what was making me reflect on was like Dostoevsky, right? A great writer or a great mind doesn't make their counter argument a straw man to just beat apart. They develop a counterpoint to be as strong as it could possibly be, and then they go to battle with it in writing. For you to prepare to be able to deliver important points, first of all, when someone brings up a point, they're at least engaging with the question, and it's an opportunity to capture them. You must have worked out all of the points that might come at you as if it's a debate and have worked through the debate counterpoint to counterpoint to not allow yourself to fool yourself that you might be missing something, and always be open to new ideas and information to then come back with counter proposals. But the better you've already laid out your virtual argument of the two strongest points, that's how you combat the information. That's how you find the really good leaders that can walk us through the nuances of the conversation. And as students, you can try and go through that exercise for yourself to try and prepare yourself.
It's
You know,
an
with
enormous.
the measles vaccine, I mean, there's been all this, and thank you, Dr. Snyder. There's been all this, misinformation and disinformation about how dangerous it is and can cause autism and all these other, adverse claims, adverse effects claims that have not been substantiated by data. And so, people are scared, and they don't understand how vaccines really work, and people fear the unknown. They fear what they don't understand. And this misinformation, disinformation machines have attacked vaccine science and for years. I mean, this is not new. This autism myth, started in the late 1990s, and it's and it continues, and because it exploits people's fears. I mean, it's like sensationalism. People are afraid, they want to see it, they latch onto it. And also, like, people can't always understand when they're being manipulated, and it's like they kind of default to what they think is the easiest course. So science communication really has to distinguish between people's like perceived risk versus their true risk, and base the communication on that. And so, as we said earlier, that just like looking at data and numbers doesn't move people to have these beliefs. It doesn't change their mind, because they're not basing their beliefs on data, or else they wouldn't believe that the measles vaccine is dangerous. So it's tied into people's perspectives and social networks, and what their peers believe, or what their families believe, or religious leaders believe, what their celebrities believe, and so to change that perspective, we have to give our own personal stories. So it's saying stories from people who've been affected and like lived experiences, or again, credible messengers of people who are like them, who what we're looking at is getting messages from people who had been anti-vax in the past, and then something happened to change their mind, and now they're vaccinating their kids. And so those are finding those people, I think, would be very effective messenger, because they're like the audience that you're trying to target. So it's a very challenging time, because people are basing their health decisions on these rumors instead of science, and even the science that is available, the public health science available, isn't is being frankly censored right now. So, just when in general, there's just some basic tenets about, how to discern if what you see on social media is true or not true. So first of all, you hear like, somebody's posting like, oh, these vaccines are dangerous. You should go to the source. Is it really a credible source? There are, and also there are so many like lookalike agencies there that you really have to like. There's the American, I think it's called the American Pediatric Society, that is trying to make themselves look like the American Academy of Pediatrics, but they're actually an anti-vax organization. So you have to be careful about that. They're also anti like there's an anti-DEI in general. I mean, they give like very negative messages around transgender affirming care, and I mean, it's just anything. It's just really awful. You also have to look at the date of the posts that you have, and make sure that it's not something from like 20 years ago. And then also understand the tone of the article. Is it like angry, aggressive? I mean, that's not an objective, unbiased article or statement. And you also have to consider your own bias, where you're coming from. And then also it's important to fact check. So look at other sources to see if other credible sources that you trust, agree with those statements. So those are just some tips in general of how to tell if something on social media is true or not true.
Just kind of a follow-up question for both of you is, how do you help people understand, lay people, the consequences of not immunizing, not especially for children, seniors? Is that a conversation that either one of you have had recently? How do you deal with that? Somebody's mind is made up. I'm not going to change. I'm not getting the vaccination. How do you approach them?
Yeah, it's that it's tough because they're not basing their decision on science, and we've really shot ourselves in the foot per se with our vaccine program effectiveness, because now we don't see many vaccine preventable diseases. All we see are noise from rare adverse events that may be associated with the vaccine or maybe not. But I mean, cause and effect, maybe they're temporally associated, but maybe not directly from the vaccine. So, and then also the vaccines are like pharmaceuticals or medication, drugs. So every drug has like good side effects and bad side effects. So of course you are gonna, if you're vaccinating like millions and millions and millions of people, you're going to have a few cases that suffer adverse consequences, and you have to be prepared for that. But it's hard to measure the preventive effects, the number of like measles cases that have been averted. So again, looking at people with lived experiences, but that doesn't even always help. I mean, I'm sure we've all seen during the pandemic in the news, there were like people were like in the hospital, like, dying of COVID and still like swearing that they were never going to get the vaccine. And I mean, I don't know if there's anything that you can tell them, or they've had family members that died of COVID and they were still swearing they were never going to get the vaccine. So, if we can just, change enough minds to get closest to herd immunity, that's all we have to do. For me as a pediatrician, it's really frustrating because if parents are making a decision to put their children at harm by not vaccinating them, and kids don't have a choice. And it was actually telling when we were offering COVID-19 vaccines at schools. We had specific clinics for students, and we received some calls from schools that said, this 16 or 17-year-old wants a COVID vaccine and their parents won't give the permission. Like, what should we do?
Mm-hmm.
Well, I mean, I couldn't can really say officially, like have somebody call that says that they're parents and give them verbal permission. But legally, there's, nothing that we could do to, provide them with the opportunity to protect themselves. So it's it's pretty scary.
That's the sad part, when adults have so much power over children who are not in a position to change the situation or get their parents to change. It's a very sad situation.
Right. I mean, when the vaccines were first approved, I mean, people were so eager to get vaccinated because they lived through the experiences of like friends and family members, or maybe even themselves. I mean, becoming ill with measles or polio or pertussis, and so they knew what those diseases were, and they were desperate to prevent them in themselves or their family members. But it's been these vaccines have been approved for and out there for a couple generations, and so people now that are the age of parents of children who are eligible for vaccines don't have any lived experiences with those diseases. And so they just don't understand how devastating they can. Measles is not just a rash. Pertussis is not just a cough. I mean, just people don't understand that.
Yeah, they fail to
The,
understand the
the one
mortality.
element of hope that I want to bring to the conversation is
Thank you for being hopeful.
it
Cheerful.
is the true beauty of the scientific method and truth. When people come at asking questions appropriately, we find ourselves in a better place.
Mhm.
There's nothing wrong with someone saying, I don't trust it. It's our job to probe them as to why, and we have to take it as many steps down with true, strong evidence. This is how this was justified from first principles. This is how we got here. These were the studies that got us here. This is how we're thinking about it here. And there, we have to recognize the scientific literature is not perfect. There's been plenty of times we thought we were on the right path and we were wrong. And you will capture more people by being honest on those elements and then trying to find where their questions are and walk them forward. Now, to Dr. Burstein's point, there's people you're never going to move. But there are also others that are asking genuine, real questions and want complex, nuanced answers. Part of our problem is finding a format where you can have the 2-hour plus conversation it takes to dig into the detail of this. Maybe the hesitancy and the pause that's coming across the country is going to allow people to ask the right questions, to dig into the real data more, to have the experts catch them up and bring them along so that there's a renewed sense of understanding and trust in the data. The science will get us there as long as it's unbiased and pure. And that's what we're in this for, is a seeking of truth. And we have to recognize I come back to the probability game. We have to prepare people for the worst outcomes that are there, because those small numbers of ones are going to have a really strong voice of when there's a problem. And we have to prepare them with again, to Dr. Burstein's point, it's really hard to get the good people to speak up because it's the vast majority. It's going to be the people that have had the injury, the risk, and the problem that are the most vocal. We've got to understand that as a community when we're approaching this. So again, I'm hopeful that science in general will win because so much of us around the country are taught the method, engage in the method, and practice the method. So there's always going to be hurdles of skeptic and sticking to communicating and really good evidence. Our topic tonight, I think, will ultimately get us to where we need to be.
If I can add that, and thank you, Dr. Snyder, that with pediatricians, where our training is for vaccine counseling, we give strong recommendations about the vaccine. And then there are going to be some parents like, absolutely not, I am never going to vaccinate my kid. And then you move on because you just don't have like, there's nothing you're going to say to change their mind, just move on. But their parents are like, well, I don't, I'm just kind of worried about this. And so you dig in, I'm worried that it'll cause autism. I don't know what to do. And you say, tell me, so you want to affirm like, yeah, I can understand you would be worried about this vaccine if it caused autism. And then so you affirm their concerns that they're real, and then you give them science, you give them data. Well, let me tell you what I know about this vaccine. Right. And then you explain that it's been shown to be safe and effective, and then also give a testimonial like, I vaccinated all my kids with this vaccine. I think it's really important. I mean, and also for me, I've had the opportunity to work in developing countries in Southeast Asia and South Africa, and I've seen some of these vaccine preventable diseases, so I can attest how horrible they are. And even with the Haemophilus influenza vaccine, it was first approved during my was approved just before my internship in pediatrics in the early 1990s. And when I was an intern, it was very common to see children with devastating diseases admitted for of complications of Haemophilus influenza infection. They would have like sepsis, meningitis, cellulitis, especially like around the eye. They would have epiglottitis, so their airway would be like completely closed up. And we would see I was really good at doing lumbar punctures, and we had to do this all the time. And then by my senior year, after we'd been giving this vaccine for a couple of years, we didn't see any cases of Haemophilus influenza. It became like really rare. And so over just a couple of years, I just saw the epidemiology of infectious diseases in children like change drastically. So, and then last week, the pediatric community, we came together and we were able to remotely, virtually get Paul Offit from the from CHOP Hospital on this participating in our meeting virtually, and he told us he's like the most famous vaccinologist still alive and a huge advocate for vaccines. And he told us, as Dr. Snyder did, that science is on our side, so we always have science. And he recently published a biography on Maurice Hillman, who was developed the measles vaccine. And he asked Dr. Hillman, like, what do you think it's going to take to get people back on track to accept measles vaccine? And this is before Dr. Hillman died a few years ago. And he said, we're just going to have to see another outbreak a large outbreak in our country, and people die of measles to bring people back. He was not optimistic that good science communication was going to be the fix to bringing people back to vaccines. So we'll see what happens, but we're already seeing measles deaths.
And there is a question in chat. It's actually a little story first. Timothy was talking about how he was a newspaper reporter in Texas during the COVID pandemic, and he has since come to Buffalo, and he's now an MPH student. Christopher, do you want to ask a question from there? Because it's very interesting, and I want to make sure that we're addressing your concerns and queries.
Yeah, sure thing. I just way back when we were starting the discussion on vaccines, I guess I was wondering from the perspective of people with longer experience, how did we have good vaccine adherence in the first place? Like, how did we arrive at herd immunity to begin with? Because in my head, I was just imagining doctors must have strong-armed patients at one point.
Well, again, after the vaccines were approved, there was generations of people who had lived experiences of those vaccine preventable diseases in their communities, among their friends, their family, maybe among themselves. So people knew what the diseases were, how devastating they could be, and so they, people like really embraced vaccines. And then and then more recently, several states, including New York, have enacted some very strong laws that require certain vaccines for children to attend school, and that's private, or public or private school. And so New York's, I think California was the first to pass a law that that only allowed medical exemptions for vaccines, because they used to allow like conscientious exemption for vaccines, and people who just didn't want to get vaccinated didn't have to have their kids vaccinated. And but they there was a pediatrician who was elected as a state senator in California, and he was able to muster the support to after outbreaks of measles and pertussis in that state to really make that law the law of only allowing medical exemptions for school entry for vaccines stick. And so New York State, we passed that law in 2019. I have to tell you that the anti-vax movement was very, very loud. And actually, after the law, the New York State Assembly voted to pass that legislation. They were in the the room where the New York State Assembly meets, and they were sitting up in the balcony, and they poured blood on the New York State Assembly members that who after they passed that bill. So and so now really the most effective intervention for uptake for any vaccine is requiring that vaccine for school entry and not allowing any non-medical exemptions. Mm-hmm. And we've been, even this year, we've seen people like try to lie and provide shady physician documentation that their children should not be vaccinated. There was one case this year in a school district where the mother didn't want her child to get a second meningitis vaccine, and she got a physician to write complete the exemption form that wasn't her physician. It was like an out-of-state physician. Physicians will hire themselves out for that. And then she submitted photos of a child with an allergic rash. Well, the school district medical director is actually really smart, and he recognized those photos were Photoshop photos. And actually and so he called the mother on it, and yes, she ended up admitting that those were not photos of her child. And he actually contacted the primary care pediatrician that gave the first vaccine, and they had no documentation of any allergic reaction. And so the mother finally conceded to get the child vaccinated, because or else he couldn't go to school. It was his senior year. And then nobody wanted to vaccinate him because there was documentation that he had allergic reaction, and it could be really deleterious to his health. So he ended up going to an allergist to get vaccinated, which was like a total waste of money. But so people are still trying to avert the system.
Thank you. And Timothy also has a question. Timothy, did you want to chime in?
Yeah, I can chime in. So I was the one that put that story out there about being a reporter in Texas during the pandemic. So I was just listening to what you said earlier, Dr. Burstein, about the different aspects of communicating effectively, know your audience, find credible messenger, that kind of stuff. I was just kind of wondering what it is that you feel that we're doing poorly, what it is you feel that we're doing, well, rather strong or succeeding in. And also, just because of my previous role, what role do you see legacy media playing in terms of, communicating science in the future as we're going forward?
Well, I think thank you for that question. I think we just have to have like one strong message and all and so people can hear the same message from different sources. So from healthcare providers, from the like traditional media, from social media, from friends and family members, from the schools. I think we just need to have one strong message and help people understand that should be our cultural norm and not these one-off people who are really averse to vaccines. So we're trying to do that. I've been working with our community pediatricians, and we've really we came together at this meeting a couple weeks ago where we invited Dr. Paul Offit, and there were probably maybe 100 pediatric providers in the room together, and just trying to work together to have one cohesive message.
Well, hopefully we will have not a serious rise in the number of measles cases this year.
Well, just one case. I mean, that's all I'm doing for a month at least.
Right. In 2000, it was completely eradicated. So to be where we are today in just a quarter of a century is astounding, really.
And it's not just measles. If you think about it, polio has had a little bit of a resurgence, and just horrible disease. I don't know that there are too many people around to remember the polio situation, but it was just absolutely horrible. So
Diane, I have a question actually.
Okay.
And I'm taking this from an educational perspective because I used to be an educator and still walk in educational circles. And one of the things that I'm hearing from some people who don't agree with vaccination is that there's a rise in autism. And one of the things I do tell them in an educational perspective is that autism has opened up and there's more diagnoses being put in it that were one time diagnosed as something else. And we're seeing that in some of the school systems, for instance, more children with an autism diagnosis as opposed to former diagnosis. But what is I just want to make sure that I have correct information to give to them, because I'm taking it from an educational perspective to tell them that it's not necessarily a rise in autism. Part of it is because the diagnoses have changed. And the whole idea of the autism spectrum has opened up a little wider, but please comment if you know more.
Right. And also, the timing of autism. So, I mean, children, developmentally are starting to elicit, behaviors or developmental delays like before they receive a vaccine.
Mm-hmm.
Sometimes, because measles vaccine, the first vaccine is between 12 and 15 months of age. And so with autism, I mean, sometimes, you'll see the language delay earlier than that, or, socialization delay a little earlier than that. So it's not, you have to kind of, look at the, timing of everything.
Yes. And I think to some extent also, I think that's difficult for a parent to see. I think that's part of it. And I also think that when autism starts to present itself is when some of these vaccines are being given. And so I think they're making close associations with that. Is that correct?
Right. I mean, just because something is temporarily associated doesn't mean that there's a direct cause and effect.
Mm-hmm.
Correct. So I'm at least stating correct things to them. I just want to make sure that the argument is there, trying to persuade some people who are, like Dr. Snyder says, and you said, on the fence, as opposed to people who have just stated, absolutely, we're not going to vaccinate. So
right. And there are like millions and millions of children that receive those vaccines and, don't have an autism diagnosis. And we started giving the MMR, the measles vaccine was approved in like the 1960, I think in 1963. And, people before that weren't developing autism at the same rate or wasn't identified at the same rate.
right. Exactly.
So nothing's changed.
Correct. I just find that more children have the diagnosis because of the fact that they've changed the way in which it is diagnosed. And whereas a different learning disability was put on their IEPs in the past, sometimes it's now autism spectrum disorder. That's what we're seeing in the schools with the IEPs. Thank you. Now Alice has a question because she wants to know how you combat the issue of your peers who are anti-vaccine, who should understand the scientific method, but choose to dispense misinformation.
Good question.
Tough one.
Yeah, I mean it's it's tough because obviously they're not listening to the science, they're listening to something else. And if they're and also like local public health, I mean, we don't have any type of enforcement authority over healthcare. So it would really be if they are not, if a physician's office is not offering the standard of care, it would really be up to the state health department to to enforce that. But it's yeah, I mean I don't know what to say because we have access to the same information, and it's kind of he said, she said. But it's yeah, it's really frustrating.
Yeah.
Thank you. And I believe, Fresh, you have a question. Is that correct?
I do. Thank you so much for your both of your time and for CTSI for setting this up. It's truly important and very timely matter to discuss. And my question was regarding the ethnic groups and also racial and ethnic groups that do not culturally believe in vaccination, unfortunately. And no matter what type of scientific reasoning is provided, it's apparently they are not convinced. So how do you combat that? Because outside of my work at UB, I do face that within the community, especially with African Americans and also Hispanic and Latino communities, that they are strongly culturally against vaccination. So if you could please share any personal experiences that you have come across, and what is your advice in combating while also respecting the cultural differences and what they decide.
Well, I know that a few years ago, I think just before the pandemic in 2019, there was I think a measles outbreak in downstate New York, in an area downstate in a large very like Hasidic Orthodox Jewish community, where many of them of those individuals, the community members, did not believe in vaccines and were not vaccinating their children. And so I think what the state did is met with community leaders and try to understand where why they had these beliefs. And some of it was misinformation about, like, I don't know, something unkosher or not kosher in the vaccine, or so they were able to work with community leaders and then get the leaders to, the message, again, getting a credible messenger. So have the leaders reach out to their community and encourage people to get vaccinated was really the best practice. But again, like meeting with the leadership and trying to understand why they have these beliefs, and then asking them to be the credible messenger.
Great.
Thank
I don't
you.
see any other questions. So Diane, go ahead. Back to you. We have about 6 minutes left.
Okay. Well, this has been a terrific experience. As expected, we have been fortunate to have two highly exceptional colleagues, Dr. Snyder and Burstein, who share their time, their valuable time with us. Some of it there are just no answers to, as one of my takeaways from today's session, but we don't give up trying. And that's part of what this workshop series is all about, is just empowering each person who attends to think about the issues and do the best they can, given whatever their situation might be, whatever their profession might be. It's just, we all have that responsibility as university, academic, medical, clinical, non-clinical, science. But no matter what we do, we're all part of a kind of a population that's dedicated to help keeping people healthy in one way or another. And it's an enormous challenge. There's no answer really, but we can't give up. That's my philosophy. My cousin just called. I just talked to my cousin in London the other day, and she told me I'm the little the Energizer Bunny, she called me. Because I never give up, she said. And I like to think of myself. I was very pleased to get that new label. But
You know, the outbreak in downstate, I think, started because they have very low vaccine MMR, measles, mumps, rubella vaccine rates in the UK and throughout Europe. Because Wakefield was actually from the UK, and so they still embrace his publication and his conclusions. And so they're very low, and they don't have any mandates for MMR vaccine. And so there were counselors who came to work in these Jewish summer camps, sleepaway camps over the summer, and I guess at least one counselor was incubating measles and developed measles, and just really hit the camp, and then kids returned home, and it came there. I mean, most of the measles cases that we've had in New York State, well, all the measles cases we've had in New York State have been travel related, with under-vaccinated or unvaccinated people going to Europe and getting exposed and then coming back, returning here.
Well, I'm glad you said that, because I'm going to a conference in Scotland in late May, and maybe it's time to get revaccinated for the measles, MMR, before I go.
Well, anybody, I don't know your age, but anybody born before 1957 is considered immune.
Immune. Oh, okay. Well, I know who to check with immunity.
Right.
But seriously, this has been just fantastic. And I appreciate everybody's questions, very interactive, lots of conversation about the issues. And we just have to keep trying. It's the only answer I come away from a conversation like this with. But I sincerely thank on behalf of the CTSI and our entire community, both Dr. Burstein and Dr. Snyder, for your sharing your knowledge and expertise and your time. Your time is very valuable. And we're very grateful for having had this experience with you.
I concur. Thank you very much.
Any last comments or questions before we?
Well, I just want to leave you with that thought that Dr. Snyder left with us is, have hope. Science is on our side. We always have science.
That's right. Don't give up.
Excellent. Thank you
Have
so
a wonderful evening. Thank you, everybody.
Thank
Bye,
you all.
everybody. Thank you very much. I
Thank
appreciate
you.
you coming. Have a wonderful evening. Thank you.